Well, the first is livers are transplanted by blood type and by size. So the first thing is you need to know the blood type. So if all your relatives are the wrong blood type, then they're not going to be a donor. So the easy thing to do is to go donate blood, and then you get blood typed, and then you know what your blood type is. We used to think that they're probably, and when I was talking in the earlier session about post-transplant, about our immunosuppression withdrawal studies, and in those studies, we used to think that if you were half HLA matched, which would mean one of your parents, since each of your parents gives you half of your genes, that might give you a bit of a protection or since other organs like the heart or the lungs or bone marrow, those all need to be HLA matched to get transplants. We don't need to do that in livers. There might be an advantage, though, to having that. So to answer your question, probably the best donor is the one that has the right size and the right blood type and is healthy, because you certainly don't want to give somebody an unhealthy liver. And in Alagille, you have to be very careful because one of your parents may not know that they actually have Alagille liver disease, and they may actually have a paucity of bile ducts, which would not be a good thing to give to your child. So that's how I would answer your question.
Yeah, it's just exactly that. It's just looking at the donor also. I think the blood type, as Phil say, um, but just also, the donor will undergo a workup basically, and decisions will be made based upon, the workup. Liver biopsy sometimes could be part of it. Imaging studies, looking at the liver, how it is structurally, because not only weight, but also, the fact the liver looks like, and you take a weight, what you want to take a weight, and there's a whole process, even psychological assessment. Always give the parent the opportunity, also to not be doing the transplant. I mean, there's all this process because, we all feel pressures that we want to do this for our kids, but you have to put in perspective, if the dad is the only one that work at home, do you want to put that person at risk when there are other 5 kids around? I mean, there's all these things that you have to look at. It's not just as simple as I want to go and donate, I have the same blood type. It's a full process as well.
We had a question over here.
I guess in the previous panel, one of the girls had mentioned that she was given a form of Lipitor to deal with the xanthomas and had some success. I was just curious, what sort of treatment options are there for trying to deal with the xanthoma issue?
Mention some of them. Yeah, David mentioned some of these things. I mean, you start with the more benign things like Western cholestyramine, things that can bind the bile acids. To deal with that, the statins is another solution. There are new drugs that has been developed, also the bile acid inhibitors that have to do with transports and product, and those are kind of the things that we know that will impact that. Somehow is related to your level of cholesterol. Anything that can decrease your level of cholesterol will have an impact somehow on that, and it will take a while, obviously. And the diversion will also take care of it. It's like a secondary gain from because sometimes they coexist, the pruritus or the itching with this xanthoma.
Oh, I was gonna wait till third. So the specific question is a complicated one and a good one. So could you inhibit cholesterol synthesis and therefore cut the cholesterol level and cut the consequences of the high cholesterol and maybe also then subsequently cut the high bile salts? And the answer to that is yes, that's a reasonable sequence. And I think many of us have done that occasionally. I think we're really concerned about using those medicines in liver disease. Nobody likes to use a medicine against like a big black box warning. And nobody knows what to really do with those medicines in little kids because their effects are much more global than many of the other things that we use. That is a study that really, really, really should be done, and no one will fund it. But it's been talked about a number of times, and you really, it's a reasonable question to say, should we be on one of these statins, which, at the adult level, I feel like we've said this several different sessions, it's like everybody on your street is on these medicines, right? Three-quarters of this panel is on those medicines. Not the cardiologist. There you go. We're not taking personal medical histories up here. Were you a child of the 60s? Yeah. But, so is a diversion or an exclusion, is that really riskier or more detrimental than a 5% risk of something at, say the liver level? And if there was liver failure from these meds, well, you're with a disease that's going to have some percentage risk of transplant anyway. So it is really a complicated question that I think all of us wish could be answered with some reasonable data because it could have a really big upside. But I would bet that almost no hepatologists have used those meds in kids under the age of 5 more than 4 or 5 times.
Because this is mainly cosmetic most of the time, and then you have to put in balance that because, as we know, these things most likely are going to go away with time as things get better and bowel circulation gets better, and most of the time they go away with time. As she was saying also, if you remember, she mentioned all these things with age went away, and she was just left with few hairs even before being treated.
I think that is certainly true, but things that are cosmetic to like an early teenage, person in general, acne can be like the end of the world, So I think there are a lot of consequences of these things that, a 2-year-old might not see these consequences at all, but an 8-year-old or a 10-year-old, you start to then be differentiated from everyone else because of these things and the fantasies that they're infectious or they're something else, and but it's one of several studies that really should be done. It's not a low risk study, but it might have actually a huge benefit for and neurocognitive, other things. Maybe they would all get significantly better, but you have this black box liver warning in a liver patient. It's kind of.
I think we have a question in the back there.
I wanted to go back to this morning's discussion about bone density scans. Is that something that you recommend for all children with Alagille, or just kids that have low vitamin deficiencies or indications? And if you do recommend it for all, at what age do you recommend that happen?
Okay, so that's a good question. We do recommend it for all. We find a large number of bone density abnormalities in a lot of pediatric chronic diseases. We're sort of working as part of a national consortium to get good normal values below the age of 4. So it's hard to compare a small growth failure Alagille with different bone structure to other kids, and there aren't other kid norms, but after the age of 4, there's pretty good data. And I think, it lets you know how serious you have to be about the vitamin Ds. And, I think there are a lot of times we see patients where the vitamin D level has been 15 for, 3 determinations at 6-month intervals, and now all of a sudden the child has rickets, and everybody's going like, why? Well, you can look back and see. So I think if you see that the bone density is really low and the D is mediocre, it's time to really up your game massively. It's the other side of the coin, and it has other consequences. in terms of fracture and other things. So I think it modifies how we treat patients and what risks we let them take, and it's kind of a nothing test. So it's like an X-ray, but it's much less radiation. It's not painful. It's not unpleasant. They tape your feet so your legs don't wiggle, and it's over in 4 minutes.
I think we had a question over here.
Back to the lipitor statin question. Actually, we've had a lot of discussion about treating the individual, and this diversion as a solution, and some of these other drugs that we're using really relies on there being some kind of drainage happening from that liver. Now, I know, my child had zero drainage. In fact, they thought she had biliary atresia. HIDA-scan negative, 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 right? And so I was wondering if we could start having more approaches looking at that, the differences between the child who has some drainage going on and using medications directed at that child versus the child who has much less drainage happening, and starting to look at those medications, because or do we always have to go through this stepwise procedure where everybody does cholestyramine, and when you fail cholestyramine, then we try something else, and if you fail that and think about diversion or not, and then now we'll experiment with the lipitor? Or can we start really looking at our kids as individuals and dividing them up into groups? Just wanted to kind of throw that out there.
Yeah, so I think it's a good question. So one thing to think about in terms of pathways is, so when you do diversion, you also pull away copper. And we've never really understood, the copper excess in Alagille syndrome. How much of the liver toxicity is copper? There's another disease that is just a copper disease. It's not at all related to Alagille syndrome, but they also have extremely high liver copper levels, and they go into liver failure, and they have brain damage and everything else, and that's Wilson disease. So that's one pathway. That's like toxins and other stuff. And if bile doesn't flow much, not much comes out in a lot of different ways. When you do a diversion, the bilirubin, which is conjugated, you throw that away as well, and then you have the bile salts and the other things. So we, in the limited number of patients where we do an external diversion, we do a DeCida scan first. There are a number of patients where DeCida, so the nuclear medicine scan that many of you probably had, sometimes called HIDA, sometimes called other things, but a Synta scan, a nuclear medicine scan at first. There are a number of people who did not excrete anything at all at 6 weeks of age, who then excrete at 2 years or 12 years of age. If you have a DeCida scan and you're thinking about diversion, and the DeCida scan doesn't show anything coming out, it's hard to think that a diversion will have enough flow to really be beneficial to you. And that is a pathway where something else is more likely to make you better than that. And so we said sometimes you're patching the feeling of itching, sometimes you're pulling stuff out, and it might be that that would be a good group, particularly at an older age, to use a statin on, of any different type. Or maybe we could sort of understand with more numbers that that's the group at age 9 or 10 that is not going to have their liver and have a good quality of life at age 20, so then just do the transplant, at age 9. It does need to be very individualized, but each of these things that we do have very different effects and different effects in different people. So it's not kind of like if you do this thing in 10 people, it's going to be predictable. It's really not predictable. I don't know if anyone in this room had like a diversion, and 2 months later, there was like nothing coming out in the bag. And so we've seen patients who have had a rediversion done several times. We've seen several patients who have had bowel calamities because this diversion is like a weird link between bowel and the skin. and other piece of bowel can get trapped over it, or it can get twisted. Everybody's shaking their head. This is, people have had bleeding from the diversion, but diversion for a number of people massively improves quality of life and stops you from getting transplanted. But it's very hard to predict which one's going to get the good and which one's not.
Okay. Real quick, are there any questions having to do with heart or vascular before we lose our off to catch a plane?
I know this is just a generalization, so it's going to be hard for you, but I thought I would go ahead and bring it up just because there might be some other parents with the same kind of ideas in their heads. With the peripheral pulmonary stenosis, and let's just say only peripheral pulmonary stenosis, moderate, not really severe, but moderate, enough to be threatening that right heart, and enough that cardiologists are saying, well, you could develop right hypertrophy and heart failure. How much of that are you actually seeing as the child with that significant but not severe enough to prevent you from having your liver transplant, and your heart's looking pretty good? How many of those people, as they're getting into adulthood, are actually going into significant failure? Is this something that we're starting to look at as we're getting an older group of kids? Where are we with that? Because I haven't gotten to read up on it.
So to answer the question, and I'm going to step back to sort of 2 or 3 steps. So the 3 or 4 different things that we look at when we try to figure out if something needs to be done, as you alluded to, was the pressure in the ventricle. But the other thing that becomes equally important is actually how much flow goes to each side. And so to simplify everything, if the flow is somewhat close, and to us somewhat close actually is not even really that close. So for example, 70% to one lung and 30% to the other, usually right, left in that order. Most of us would not do something simply for improving the blood flow to each side. Okay? If the pressure in the right ventricle is less than or equal to half the pressure on the left side, most of us would not do anything about that either. And that data comes from kids with other forms of heart disease, that we know that the right ventricle can handle pressures that high, even though half of the left side is not, quite frankly, really that high. When the pressures start creeping up past half of the left side, what's known as half systemic, or the flow is more disparate than 70-30, I think that's when people tend to intervene. And I think, to be perfectly honest with you, that while there's always those in the gray zone, the overwhelming majority are actually black or white. They either come to us with significant flow discrepancies, 80-20, 90-10, and significant stenoses, such that their pressure is high enough that the liver team wouldn't be happy in a perfect world with those kinds of numbers. And they're higher than half systemic, which would run the risk of long-term heart failure. So those are the criteria that we look at, which is flow distribution and overall pressure. While those can change over time, in general, they tend to stabilize. They tend to stabilize. So if you have a couple of numbers in a row and they're not progressing, they don't tend to progress. Okay.
I would like to ask a question. Balloons, cutting balloons, stents, restents, patch, resection. When, were, why, how, and something else.
So the easiest answer to that question is, in general, what happens tends to be based on what your institution knows and what your institution is good at. Good being a relative term with no disrespect meant, there are programs around the country where in those surgeons' hands, the results are spectacular. There are programs around the country where surgeons can do a very good job, but they can't necessarily get to all of the narrowings. So one of the issues with the surgical approach, and this is why, in fact, the balloon approach caught on, was that The narrowings that are very close to the heart are very easy for the surgeons to get to. The narrowings that are out much, much further towards the sort of the sides, those are incredibly difficult for many surgeons to get to. Now, there are surgeons that can get to them, and I'm spectacularly lucky in that we have a surgeon that can get to those. And Dr. Hanley is known not specifically for dealing with these particular lesions in Alagille's kids, though they do get these lesions. But there's a whole population of patients with what's known as tetralogy of Fallot and major aortopulmonary collaterals, also known as MAPCAs. And I was saying to somebody before, most programs will see one of those a year. We see 50 to 75. And so it's a natural extension for our surgeons to work on those type of narrowings, those types of stenoses, the stenoses that are associated with Alagilles in our ORs every day, basically. So in our surgeons' hands, our cath team doesn't even look at them. In fact, the only reason we send these kids to the cath lab is for pressures. We don't even do it for pictures because we get pictures by other methods. So we go to make sure that the pressure is in fact high enough to warrant that anything should be done. And once that's done, it all gets turned over to the surgeons. There are many programs who believe that balloon is the right way to go. And there are a couple of papers out there that say, you know, we can do this and quote unquote, it's successful. But based on the leading question, which was balloons and cutting balloons and stents and restents and reballooning, I personally am not a huge fan of balloons, stents, cutting balloons anyway. And I will tell you this not only from personal preference, but personal experience. Until about 5 or 6 years ago, I was an interventionalist. I was doing the ballooning, and I saw the results, and I wasn't impressed. I think that the use of balloons in peripheral PS or pulmonary stenosis in other diseases and other reasons, I think it's actually quite successful. I think the blood vessels themselves in Alagilles are very different. I think the results are very different, and I think the complications are not inconsequential. So if you read the papers, what you'll see is there are tears, there are dissections, and we see this in other diseases and other balloon procedures as well. But again, the big piece is what you then see is, and we went back the next time and we did it again. So to me, I think you don't get the same bang for the buck as when you can get actually a full repair surgically. Again, it has to be in the hands of a surgeon that does a lot of this and is comfortable working very far out from the center of the vessels. But again, we go back to sort of the very first question is, don't do it if it's not needed. And I think that's the biggest thing. And unfortunately, I've said this a couple times, the natural reaction by many cardiologists is if you see a significant narrowing, you have to go do something about it. That's not always true. If they don't meet the criteria that we talk about and they're not at risk for RV failure or lung non-growth, if you will, leave them alone. Just leave them alone. Was that even close to an answer?
That was an excellent.
There you go.
And he's literally off to catch a plane. So let's thank him so much. Thank you, Dr. Feinstein. Okay. Other questions? We have another one at the back there, Anna.
Thank you. So going back again to this morning's conversation, there was a lot of information, and we appreciate it. But now that we've had a little time to digest, as part of the discussion about the use of ibuprofen specifically, there was sort of an aside mention about it not being such a great idea with kids with low platelet counts. And I was a little curious about the definition. I don't know about other people's experiences, but low normal versus a low Alagille kid is sort of different. So when you say that, what do you mean by low? How low? He totally said
Was
it.
me, my evil
It's like
twin
hot
was
potato
here. No, I, as I said, I don't think one dose, 2 doses is going to be a big deal on the long run. I definitely will cautious if you are talking about anything under 60,000. I think in general that's when people get a little bit more worried. If the platelets are over 100,000, I think usually you are good and probably have the same risk as anyone else that do. But I think the main principle is not getting into just give it every time it has pain, or all these things that we talked about this morning. You had to be cautious of when you start into chronicity, more than 2 days. While you are doing this, the kid's having fever, we have to evaluate this. We are missing something on the kid. But I think those will be more or less the parameters. I mean, there is this is coming from some of the risk mentioned by our colleagues in hematology when you get certain levels, or also when you do procedures, some things that we have learned about.
Yeah, so I'm going to answer the easy part of your question. Of course, what is low platelets is less than like 150 for most of us. But that's not so low that it makes any of us excited. So I think I looked at somebody's labs today, and the white count was 5.9 and the platelets were 180. And my first question was, and I bet they feel a spleen, because even though those numbers are both normal, that's low-ish, and that's a sign that the spleen is, big. But, there are a number of classes of drugs, like, and again, we're not polling the crowd for who takes the statins, but, many guys over the age of 40 take aspirin. And what's the point of the aspirin, that little baby aspirin? It's to poison our platelets. And it has a plus and a minus, and the minus is it might make you bleed. Now, ibuprofen and aspirin are not obviously quite the same, but, similar pathway sort of meds. So my bigger worry is people take those, and they take their aspirins on a dry stomach. That's just not a good idea, and you will get burned literally once in a while. And when there's so much extra blood under pressure in the stomach wall, it can just be, profoundly worse. So.
I'm gonna right over here.
Yeah.
My question's around vitamin K, and I know you kind of touched on this earlier this morning with some of the challenges with vitamin K being extremely expensive, and we're certainly crossing that bridge as we speak. And I've contemplated moving my daughter from the tablet form of vitamin K to the injection. I was wondering, in terms of care, what is the frequency that we would expect if we were to move our daughter from daily tablet form to an injection, and potentially some pros and cons either way with moving in that direction?
Yeah, that's a great question. I don't know if I want to tackle it. Anybody else want it? Okay, so vitamin K has become incredibly expensive, and for some people it's not covered, or the copay is out of sight. And if you make it up as a liquid, sometimes it's even massively worse.
Yes.
And somewhat amazingly, if you get it injected, you may pay no copay at all.
That's correct.
And so, it's a shot, but it really works way better by shot than it does by oral. So how many people in here have been on high-dose oral vitamin K and it didn't work and they just go to shots? Is there anybody? Yeah. So there are a couple, and I think this is something. So sometimes it's a medical decision, and the finances don't matter, and then people come back and go, oh my God, I'm saving $300 a month by doing these shots. The kid doesn't always say it's worth $300 to get. So how often do we do that? So I think you titrate it. You measure the effect, and so first of all, if the PT is like 13 seconds, it doesn't really excite real liver doctors at all. So if you're really spending all this money and doing, but if your PT is 17 seconds, so get a shot, wait 2 days, and then see what the clotting time is. And because it takes a little while for the liver, given fuel with vitamin K, it takes a good liver a little while to make enough of good K clotting factors to bring the number down. So then that number, that's your good number.
Okay.
And let's say that number's 11. Then go get another PT 2 weeks later. And, if it's 13, you're good. That's a time for a shot. If it's 17, you need to go to a shorter interval. And so you can titrate it because it's not really predictable. We have I don't want to say a lot of kids, but we have, our strategy is not uncommonly, just like Jeff said, use 2 negatives to really obfuscate what you're saying. 7 to 10 day intervals, 7 to 14 day intervals. You're not going to be able to do it like once every 3 months. That's not going to work.
Okay, that was
Yeah.
my question because we're traveling out of state for my daughter's GI care, and so it's not like I can, walk.
Oh, but your
every other week.
pediatrician can do this, no problems.
Oh, okay, so it doesn't have to.
Oh,
be.
you can get a home nurse to do it.
Oh, okay. Well,
Oh,
that's
you
even-
get delivery.
Oh, that was going to be.
He'll
my
do it
second
for you.
question. That was going to be my second question. Okay.
Oh,
well,
yeah. And sometimes you feel like, oh my God, we have to do this way, and it's your fantasy, but you can always ask, gee, what's the simplest way to do this? What's the simplest way to make up this medicine? Yeah, I mean, we give vitamin K shots if our families have been bad and they don't get it where they're supposed to get it. We look at them and like, when did you get your last shot? But yeah, the pediatricians give them, home nurses give them, and they're usually
excellent.
covered under your home nursing pharmacy benefit. And so it's striking. The expensive medicine gets paid for, and and we've sometimes just cheated and said, you know what? You have coagulopathy, your nose is bleeding, go to the emergency room, tell them, make it a 10-minute visit, really what you need, squeeze the nose, give me a shot of vitamin K, see you later. We don't need 50,000 things. And that's totally covered,
Okay.
So,
No, thank you for
yeah,
that.
but
Perfect. Okay, other questions? Anything else? Nothing else? No? Okay, going once, going twice. Okay. Well, thank you all. Let's give our wonderful doctors a big hand. Thank them for their time. It's been a long day. We will meet back here at 6:30 for our celebration dinner. We have some entertainment. We're calling it our unraffle. We have some great prizes that people have brought and some other great prizes. Some dancing, some music, and we're going to have a great time. So back here at 6:30. And yeah.
having our photo immortalization
Yes, and
of
it's
the 7th
and
International Family
exactly.
Symposium.
And it's a tradition to have a group photo, and that will be tonight as well. So please come. Yes. Oh, and Denise, one other thing.
Okay, so the program says that dinner starts at 6:30, but we're not going to put food out till 6:45 because we want you all out in the terrace garden for the group photo.
Okay, at 6:30.
And we'll do it in 15 minutes, right?
Yes.
But we're all going to be directing you past the buffet out to the garden for a picture.
No food until the picture's taken.
That's right.
Okay. Thank you all very much.